Dr. Ganesh, could you tell us, are there any treatments currently available for long COVID, and what treatments/interventions are currently being investigated for this condition?
Nothing's FDA approved, and everything that we use is kind of cobbled together from our understanding of other chronic illnesses. So generally, I tend to phenotype people to kind of see which conditions their long COVID most closely resembles, and we try to devise therapeutic intervention based on that. So, for example, our patients who have more of an ME/CSS phenotype, the things that have been most helpful historically for that have been things like low-dose naltrexone, low-dose Abilify. We've done a bunch of different supplements for it as well. Pacing is critical, trying to get people to not overexert themselves and have that crash. Trying to help people understand how to minimize and mitigate stresses and exposures in their day. Even things like too much exposure to stimuli can be greatly triggering as well. And then helping people with the accommodations that they need for their ability to work. A lot of times people either can't or need a greatly reduced schedule. My patients with orthostatic intolerance may need to be sitting for the majority of their day. There are things like that you have to do. For people who have kind of more of the dysautonomia phenotype, and I'll defer to my colleagues on that. She's a world expert. There's a lot of things that we can do that have been more prevalent in recent years. I personally use vagus nerve stimulators for people with that hyperadrenergic type of dysautonomia post-COVID. We have medications for POTS, which include things like beta blockers, fludrocortisone, midodrine, which can be used with varying efficacy based on who your patient is and how they react to them. And then we have a lot of non-pharmacologic things as well. The patients without post-exertional malaise can actually tolerate some degree of physical activity, especially if it's not vertical. So there are some activities that we can do to help them regain some tone as well as not really challenging that orthostatic intolerance. So kind of a mixed bag in terms of symptoms and treatments, and I can't give you a straight answer on it. In terms of what's being trialed, there's a few things being trialed. The RECOVER trials are looking at things like IVIG, they're looking at Paxlovid, a couple of studies looking at things like sleep, and one looking at effective activity. Then there are a couple of non-RECOVER trials that are pretty interesting to me, including the one reverse long COVID that's being done with baricitinib, and hopefully should go live next month. So I'm eagerly hoping to see what happens with that one.
There isn't a magic cure yet. There isn't a magic pill, but the important thing is like figuring out the phenotype, because a lot of things there can be symptom management for what the patient has. So like so many patients have POTS or some other kind of dysautonomia, and there are things both pharmacologic and non-pharmacologic that can be due to control the symptoms. It may not take it all away, but can we control things, and I just feel there's so much fear of like starting someone on a beta blocker when they need it, encouraging, please try to take care of these patients and offering these type of treatments. And there are guidelines that are out there, guidelines that we've published that are out there for these things. There are really important, again, screening patients for post-exertional malaise, because if they have that, then you have to make sure that you are figuring out where their energy envelope is and how much they can do, and not letting them push themselves, because they can push themselves and they can crash. And there have been studies showing that sometimes if you exercise a certain population of these patients, their muscles actually have more necrosis in them. And so you're actually doing something worse for the patient to exercise. So you kind of really have to listen to the story and figure out, is this someone that needs to pace? Or is this someone where, I'm a rehab physician, and some patients need appropriate, very patient-centric, very listen to how the patient recovers, activity modification program. And some need it to just decrease their modification, and some may able to slowly increase their activity and do more and more. But again, listening to your patients, seeing how they're responding to the things that are doing. We see a lot of patients, breathing is even really hard. It's a natural thing, but it's part of your autonomic nervous system. So you don't think about it, but there's a lot of dysfunctional breathing patterns. So really like breath work I see is some patients, they just love their breath work. I guess that's the equivalent of vagal nerve stimulation. poor man's vagal nerve stimulation and having them do breath work and also retraining their diaphragm again to just be able to take deep breaths and to breathe when they're supposed to breathe. Long COVID can be so many things. If a patient has migraines or an exacerbation of their migraines, you don't ignore it, you treat their migraines. And sometimes you have to treat it more aggressively. If they have chronic migraine now and before it was an episodic migraine. If they have sleep disorders, if they have, working up the sleep disorder, see what it is, do treatments. There's a lot of symptom management that can be done, even though I don't have like, you need to take this autoimmune medication or, oh, we'll just get you on IVIG and it'll fix everything. The other thing that I had dealt with long COVID myself, I did a treatment called enhanced external counterpulsation. It's something that they used before in cardiovascular diseases and in angina. And so it kind of helped with my exercise intolerance. And again, that's something that's not offered every place and for every insurance, but was something that I'm able to offer some of my patients to help with some of their symptomatology with long COVID. And then using all these other medications that we have, treating underlying disease states that may develop.
I agree with my colleagues. That's very thorough and appropriate approach. I only want to caution that sometimes I have patients who come to me from various long COVID clinics. And when they tell me what was offered to them, a lot of the times it's actually insufficient. So usually what's offered out there may be, a sleep evaluation, but let's acknowledge that that's absolutely not enough for a majority of patients with long COVID. So as my colleague said, the long COVID is a huge umbrella for multiple phenotypes, and you can't really pick and choose and concentrate on simple things because lifestyle measures are very important, but it's not going to be the answer for a majority of long COVID patients, many of whom will need medications. So I think my additional comment is that we all have to learn how to manage these patients. Even if you've never managed POTS or if you've never managed neuropathic pain, you will have to learn when you're dealing with long COVID patients, because that's an essential part of treatment that we have to offer. I think it goes without saying that education of doctors of all specialties is going to be critical to improve patient care and treatment approaches, because we can publish various guidelines. We have them and we continue to publish, but if you're not reading them as a neurologist, as a physiatrist, or as a rheumatologist, or as an internist, you're going to be stuck in the old pattern. I call it being stuck in the old pattern. And the old pattern for post-infectious syndromes were to look at the patient, to get their blood work, which mostly came back normal, and say, look, you have so many symptoms. Are you depressed? Are you anxious? Are you not sleeping well? And then send you off on your merry way or cognitive behavioral therapy or exercise therapy. And while these therapies are very important adjunct treatment options, we have to remember that underlying process of patients with post-acute sequelae of SARS-CoV-2 are, viral persistent, immunologic abnormalities, autoimmunity, hypercoagulable state, and you can't exercise your way out of those. There is no diet that will address that. There are no sleep patterns. So I think looking at the big picture, we all have to acknowledge that while in my field, neuropsychiatric manifestations of long COVID, obviously there, and they are numerous, it's not the whole story, and we have to do better by our patients. We have to give them medications, even those medications that you've never used before. I know, for example, many neurologists have not treated POTS. They're not comfortable with, Corlenor or Midodrine or fludrocortisone that we use as first-line therapies for POTS. But as I always say, if you are practicing out there and you're seeing long COVID patients, you have to get familiarized with these other medications that we have that can be quite effective.
And if you were to ask me what my wish list was for patients with long COVID, besides a cure and understanding pathology, it's that they could get good care locally. Because I don't think that it's a service to our population that they have to come to a tertiary or quaternary care center just to get diagnosed or to get trialed on some meds. And then When I get them back home, the ability to have them stay on those medications is incredibly difficult because most physicians won't continue them. And I've heard so many times, I've called and personally spoken to physicians, and they're like, I've never used this. This is not FDA approved, and I'm not going to use this off label. And it's just a very hard stop. So on my wish list is that we have better uptake in primary care across the country.
I still have a hard uptake of some people, even clinicians, believing long COVID is a disease. Just had a colleague today say one of the patients she saw was told, long COVID's not real, you're just depressed.
Ultimately, we want a lot of tools in our therapeutic toolbox because it's not going to be one size fits all. There isn't going to be one nice biomarker, and there's not going to be one nice treatment for all. Some people will do well with oral medications. Some people will need infusions. Some people will need immunotherapy and immunomodulating therapies. Some people may need antivirals. So I think the more we get, the better it is, because we need to think about multiple sclerosis and how many FDA-approved treatment options we have now to offer to patients. This is my wish list as well, that we'll have a lot of different options. Some may be over the counter, some will be non-pharmacologic, and others will be heavy-duty immunotherapy modulators, but we need to have them FDA approved and accessible to our patients.
Some patients may have more than one of these pathophysiologies that's driving their symptomatology. So once I had it explained to me, and it makes total sense, think of like a ship with an anchor, but sometimes these patients are a ship with like 3 anchors. And so you could take away the anchor that is autoimmunity, but they may still have an anchor that is hypercoagulability, and they might still have one that has to do with like mitochondrial dysfunction. So you really, in each patient, have to, eventually we have to figure out like what is driving their symptoms and then get treatments for each of those things.
And then I think going further is that we just need to study this population of patients who end up with the sequela, because when we go with science, then we'll see some kind of genotype and phenotype that is predisposed towards these post-infectious lingering symptoms. We know one is going to be joint hypermobility, where patients were maybe fine, maybe had some allergies, some minor aches and pains, some migraine headaches, and now after COVID, they are very sick. So I think genetically, we hopefully will identify which type of genes are responsible for this infection-associated syndromes that are very disabling.